I have the great pleasure of introducing our next speaker, who is going to talk about robotic bronchoscopy, risk stratification and screening. And we have Dr. Bradley Icard with the Pinehurst Medical Clinic, Chest Center of the Carolinas at FirstHealth. Let's welcome Dr. Icard.
Good afternoon, everybody. Mic sounds hot. Can everybody hear me? Okay, good. Well, it's an absolute pleasure to be here today. My name's Brad Icard. I am the new director for lung screening at the Chest Center of the Carolinas and FirstHealth, and a pulmonologist at Pinehurst Medical Clinic. Prior to joining there, I was in Triad at Cone Health, and just recently relocated. So we're in the process of moving down to that new facility. So today we're going to talk about robotic bronchoscopy, and I want to talk a little bit about the history of screening and kind of understanding a little bit about why we do it today. And I want to equip you a little bit with the tools and kind of understanding why we're doing it here and why we want to grow it in North Carolina and across the country, but in the space here. Current dilemmas in robotic bronchoscopy, talk a little bit about nodule risk stratification. In 1968, the World Health Organization got together and made up some recommendations on what patients should be screened and why. And really it's asymptomatic patients, and this is for all things, right? Not necessarily just lung cancer. But is the disease important? Does it have a natural history that we understand? Is there treatment for early disease? Is there an effective screening test? And do we have an acceptable target population? And these were kind of like the ground rules for, hey, should we screen? Whether that's breast, colon, whatever that may be. And of course, lung cancer fit this. But at the time when we were thinking about this, we didn't have one of the things that we didn't have was an effective screening test, right? But now we do. We have a low-dose lung cancer screening CT that allows something to be effective. But before 1980, the American Cancer Society actually recommended annual chest x-rays and something called sputum cytology, where people would cough into a container. A pathologist would look at that under a microscope to see if there was cancer cells. We know now that if that is the case, or we find something like that, that's way too late in the diagnostic pathway for that. But in 1980, after looking at the studies and the things that were found, actually the American Cancer Society said, hey, you know what? There is actually nothing that's effective at lung cancer screening. It didn't demonstrate any benefit in reducing mortality. Don't do these things, okay? So we've come a long way. In 1999, in Lancet was one of the first published studies of the New York or Early Lung Cancer Action Project. And it showed a 5-fold difference, meaning 5 times more likely to find an early stage cancer with a CT scan in comparison to a chest x-ray, right? Back there you can see that's what a standard chest x-ray looks like. CT scan obviously has many, many more images of the torso that collects images from the apex of the lung all the way to the basis. And 85% of the people that were diagnosed with malignancy in this study were stage 1s. And this is where it really started to kind of like, hey, maybe we can find this early. And then as things progressed, we started to see other trials come out. The National Lung Cancer Screening Trial is kind of what most people remember, and they still dig in and look at that data. It was age 55 to 74. That's how our first recommendations came out with the U.S. Preventative Services Task Force. And then the Nelson trial was in the Netherlands, and then the MILD trial was in Italy. And then as we started to see this, guidelines started to change over time. And so as guidelines change over time, you can see here 2013, the American Cancer Society, U.S. Preventative Services Task Force in 2014. The reason this is important is these are how groups of people that get together to help make decisions for these to be approved by insurance providers and start changing of guidelines for recommendations and management. But as you can see, it can be confusing. And then as we move forward, the ones that we see there below are the most recent ones, and guideline recommendations between now and 50 and 80 years old with a 20-pack year history of smoking or quit within the past 15 years. So as you can see, since 1992, the Early Lung Cancer Action Project started. published the data in '99, and then since then, we've started to see all of these additional trials that have come along the way as we move there. So screening for non-smokers. Right now, we don't have a recommendation for this, but it is something to keep in mind and to have a discussion with your provider, right? That doesn't mean that we can't get imaging in non-smokers. It takes a little bit of discussion and documentation as to why we think it is important to potentially screen. It may not be a low-dose scan, but it could be a non-contrasted regular CT scan that we get on patients. And I've had situations before, patients that come in that have strong family history of malignancy in the lung and have been non-smokers, that we have made decisions on scanning and have caught early malignancies on. So it's something that you have this. And I think we'll see more and more of this change, because when you look at lung transplantation, for example, the second leading cause of death in lung transplant patients is lung cancer. And so these are all reasons to have that. And if you have COPD in and of itself is a risk factor. So there is reasons to obtain imaging on patients like that. And if you are seeing a pulmonologist or seeing somebody like myself that is actively engaged in this process and understands why we need to be screening patients, no matter. Things that we don't understand yet and how it's going to impact us in the future, one of them is air pollution. I think this is a great study that is out of Taiwan, looking at the increasing rates of adenocarcinoma that tracks right along with the increasing pollution rates for that city. So as the city has become more populated, we see higher pollution rates. The American Lung Association just put out an air quality report. They put those things out every year. We don't know how that affects the incidence rates of lung cancer in cities like New York and Los Angeles, but we will get there, right? Chinese lung cancer screening guidelines from the Chinese Health Ministry changed this past year to include family history of lung cancer, higher areas of incidence, secondhand smoke exposure. So it's very telling, because these are guidelines around the world that are starting to change. So that's important to us, because as we start to screen more patients, we need to figure out what we do with all of the scans that we're getting for people, but how do we make sure we're not missing important groups? The FANS study is currently still ongoing. The FANS study is the New York Female Asian Non-Smoker Screening Study. This is any Asian female that between the age of 40 and 74 that has smoked less than 100 cigarettes in a lifetime. So effectively non-smokers, right? And what's staggering is that 1.5% of this population that is currently under investigation has EGFR positive lung cancer. And so that's 1 out of every 100 Asian females that are diagnosed with EGFR positive adenocarcinoma. And so what do we do with that information? We don't yet know, but the data itself was released at World Congress this past year, and these are the types of studies that will help change guidelines as we move forward on patients who we should screen and shouldn't screen. What we have to do, and what the scan van needs to do out there, is help us fix this central data point. 22% adherence rate since 2014 until now, or this data came out 2023. So from there, that's when the ACR, the American College of Radiology, we have a registry in which all of these lung cancer screening CTs get dumped into from health systems, okay? And we had screened 1 million people through the ACR registry, okay? The sad part about that, there was only a 22% adherence rate, meaning people got their scan one time and maybe didn't get it the following year, or maybe got a scan 2 or 3 times and then again, so to be successful at screening, it's something that should be done yearly so that if we do find something, we can act on it early, okay? The nice part is that 53% of those patients in that registry were diagnosed that had cancer, were diagnosed at stage 1. So we know that the mechanism works. Average across the country at diagnosis at stage is 26% for lung cancer. Stage 1 across the country, on average, 26% of the people are diagnosed with stage 1. So that means if we include them in a screening program, we can almost double that number. So we know that we can do it, we just got to get people. These are all stage 1 lung cancers, and they all are not equal, right? That's one thing that most people misunderstand, right? So this is a T1A lesion. It is very tiny, right? Less than 10 millimeters. It has over a 90% 5-year survival rate. This lesion over here is greater than 30 millimeters. It is still a T1C lesion in size and a 77% 5-year survival rate. That has the same outcome as a stage 3B breast cancer. They do not behave the same. So there's a common misnomer between hearing stage diagnoses and survivability or outcome in that. Every cancer is different, and that's why it's part of the discussion of understanding what the pathology is. And that's even different when it comes to small cell versus non-small cell. Effectiveness of screening. These are other facts that I love sharing that people just don't know, right? Colonoscopies, it takes nearly 1,000 of those to save one person's life. So what's called the absolute risk reduction, or 1 over the absolute risk reduction, is statistically something known as the number needed to treat. In this case, number needed to save a life. So that means if you took it's the recommendation at 40 years old to have your colonoscopy, we have otherwise 1,000 healthy people, no symptoms, to get their screening exam for the first time. We'd have to do 1,000 people to save one life. Okay, nearly 900 mammograms, same thing for ladies for mammography. But for lung cancer screening, it only takes 320. You say, well, why is it so effective? Well, it's because we're taking an at-risk population and we're boiling that at-risk population down and screening the at-risk population, right? Very different than taking a full population level approach for something like mammography. All right. Am I talking too fast? Okay, good. All right, let's talk about robots. That's my favorite thing. I'm a robotic bronchoscopist, and we're going to talk about some fun stuff. When you think about bronchoscopy, we've struggled for years on trying to figure out how to get into the chest cavity, right? It's kind of like Pandora's box. It's just one of those things that you're not really easy to get into. There's vital organs inside of there, the heart and the lungs. You can't stop people from breathing while you're working on it, right? So there's other ways that we have to get in there. And one of the ways that we do that, minimally invasive now, is a robotic bronchoscopy. And so, we used to do wedge resections or VATS with thoracic surgery, and then CT guided biopsies, and then E&B bronchoscopy, which is electromagnetics, which is something that we used to do, and then just standard bronch. And so where does the robotic role fall in place? There's 3 robotic platforms on the market: Monarch, Intuitive's Ion, and then the Galaxy robot. Those are 3 that are on the market. I am an Ion user, for full disclosure. There's electromagnetic platforms. These kind of operate still on that platform. Shape sensing is the Ion system. Very small, right? These things to point out. It's 3.5 millimeters. It's driven with a console. This one's about 4 millimeters. It's got something called tomosynthesis. So they all operate a little bit differently. But when you think about data, and the reason I put slides like this in here is to talk about a lot of times when patients see study reports, or when caregivers see study reports about, well, this one works better than this one, or this thing works better than that thing, or you have to take that piece of information with a grain of salt, okay? You have to understand a little bit more sometimes about what you're looking at, because these are 1,000 hypothetical patients, and we applied these different 5 methods on diagnostic yield, for example, between biopsies from 4 different trials. And these were all the same patients, but you can see here the diagnostic yield in this particular work is very different based on the method of how it was calculated, right? So when you see those things advertised, or you see stuff may come across on a commercial, you got to understand that there's a little bit more that goes into that, right? It's not necessarily false advertising by any means. It's just how the data, and you have to understand how the data is processed. And that's why you go and see your clinicians, and that's why the doctor sits and talks to you about the pros and cons and risk benefits. It's because you're hoping that they've taken the time to understand that data a little bit better. These are all the current robots that are on the marketplace, and the kind of the stuff that's out there. What we want to look at is how small can we go, right? So how accurate can we get, and how small can we go, and when to biopsy and when not to biopsy. So sometimes We have patients that have little tiny things, and there's this lesion right here. You can kind of see it. See this little fuzzy kind of cloud right there? And this is most likely an adenocarcinoma of the lung. It's probably a lipidic adenocarcinoma. But the patient that I saw this in, I think was probably in their late 80s. And then we got to decide, like, what do we do with that, right? And quite frankly, it's not uncommon to find these. And this is a kind of malignancy that probably you would die with, not from, right? And so we have to have some kind of conversation around, well, what do we do in those situations, right? Because there are types of malignancies that behave differently. And that's why it is important to ask the questions about, should I do something with this and should I not? Nodule risk stratification. Separating the wheat from the chaff. You got to remember that what is a lung nodule? We usually get this, people get these questions, they don't really understand what that means. Nodule is just a definition based on size. Okay, so lung nodules in and of themselves are anything less than 30 millimeters, and anything greater than 30 millimeters in size or 3 centimeters is a mass. Okay, that's just a terminology that we use. And then there's many different forms, right? So here's a macrolobulated nodule, here's a smooth nodule, here's a subsolid lesion, here's a very large spiculated, right? So it all based upon the way they look like. Every single one of those are lung cancers, okay? But they all look different, okay? And these are all not lung cancers, right? So you got to remember that the majority of nodules that are found in the chest, 90% of them are benign, right? That's what keeps me busy every day, right? So every day in clinic, I see a whole bunch of people with nodules, and I tell them, you know what, don't worry about it. There's nothing to worry about here. My job is to figure out the ones that I've got to worry about, and that's that risk stratification process, and it also comes with people that looks at them day in and day out, over and over and over and over, right? And so these are all common things that we find in the chest cavity and diseases that are caused benign lung nodules, okay? So we see it all the time. And majority of the time, I can't ever tell patients what caused their nodule because they come in and they got a random scan that was done in the emergency department for whatever reason, and they see me, and then I talk to them about their scan, and I say, you know what, we'll repeat it in about 3 to 6 months, and we'll see what it looks like, and usually it's disappeared by then, right? And if it's disappeared, it's something that we don't have to worry about. If it stays around or they're high risk, right? Like there's high risk patients like we talked about, then we may have to do something. So history, behavior, and then there's lots of other stuff that's out there. Do we do risk calculators? Do we do blood testing? Do we do image-based work? And these are all things, but like I said earlier, a lot of these are found incidentally. They just show up in the ER or something like that. And believe it or not, incidental found lung nodules, so meaning that you just didn't know you had one but found one, those are actually higher risk for the development of malignancy because a lot of times patients that are getting scans have other comorbidities, right? Let's say you're getting a heart scan and you find that. Well, people with heart disease also tend to have a tobacco abuse history, so they are grouped together in those comorbidities. There's tests that can be done, and these are some things that we do to help kind of calculate patient risk. Meaning that we punch you in, try to figure out a probability of whether or not that's there. These are kind of the landscape of what we're going on right now, of trying to figure out how do we stratify nodules, right? There's natural language processing, which is a computer-based systems that help us detect nodules early. There's things that are in the EHR or the electronic health record that help us on population base. There's biomarkers. There's something called proteomics, which is a blood-based test that helps us differentiate high-risk nodules. There is a genomic sequencing with a respiratory epithelial swab that's out there right now. And then there's other devices like we talked about from RobotSnap trial. This is just for fun. This is the Panoptic trial, came out a couple of years ago, but just to let you know, there is a blood test that we use that can be helpful in risk stratification for nodules. The Oracle trial was published this past year. They said that if we did do the blood-based tests for nodules, then we could potentially decrease the number of invasive procedures, which is good because, I got a waiting list of people that I need to get in for procedures, right? And so if I can separate the ones that need to get in sooner, then I can get those people in, right? So these are the things that are part of that. This is the genomic sequencing classifier with the brush that's done inside of the airway. This is a clinical trial that we released prelim data on at CHEST this past year. But that particular trial, of the 43 people in the first part of it that were diagnosed, of the people that had it done, the 43 people that was low risk didn't have malignancy. That means they had a good negative predictive value. So it'd be great one day to have a test that, say, God forbid, Dusty sees me one day, she has a CT scan that showed a new nodule. Could I do a nasal swab in the office that would say, oh, you know what, that's negative, I think it's low risk, maybe we can scan you in a year and feel comfortable about pushing that out, or trying to get rid of some of the scan anxiety that comes along with having something like that done, right? And these are all the things that we're kind of working on. When to PET, when not to PET. People hear that a lot too, like, oh, I'm getting a PET scan. Why is that being done? Well, depending upon what it is, if it's a small lesion, like you see this here, there's hardly any PET activity on a very small subsolid nodule. There's still a lung cancer, but so patients get really confused sometimes when they have a PET scan done and then it's negative, but then they come and see me and I still tell them, hey, I think it's a lung cancer. They look at me like I have 3 heads, but they're like, my PET scan's negative. Well, it's because the PET scan is used as a tool to help us determine probability. It is not a diagnostic intervention of any kind, right? PET scans are not diagnostic, and that's also a common misnomer, is that people think, oh, well, my PET scan's positive, I must have cancer. Well, no, that's not the case. Okay, there's got to be some more information behind that. Okay? All right, are they safe? Right? Absolutely, right? So in robotic bronchoscopy, as a less than 1% roughly pneumothorax rate, less than 1% bleeding complication rate. Traditionally, we biopsy people with this big needle that goes through the back of their chest into their lungs, and you can see here it causes things like this, which is pneumothorax, when your lung starts to collapse. This is one of my patients that I ultimately ended up going in to biopsy this without a complication, but this is, as you can see, it is safe, right? And so the American College of Radiology published this, and they looked at nearly 17,000 patients that had CT-guided needle biopsy, and 25% of people with CT-guided needle biopsy had complication, right? And so if we can do it now robotically and inside out almost, right? You know, working from the inside of the airway, we can do it better. You know, so the real question that I have is, what can a robot reach, right? You can see this is a little tiny lesion. It's 5 millimeters in size, to give you an idea that's smaller than a green pea, right? 5 millimeters smaller than a green pea, about the size of an eraser on a pen. So this robot is pretty cool. It can bend and make its way around inside of the airway. We drive it down through here, and we look at it under fluoroscopy, under real-time imaging, and we're able to stick a needle in it. You can see there's a needle sticking out of the end of the robot. All right, and so a target, when I'm thinking about targets and when I'm thinking about biopsying something, it's really like real estate. It's like location, location, location. How do I get there? Are there other factors that I need to worry about? Do the people have other disease of the lung that I need to worry about? Have they had prior surgery? Because that may change my roadmap on how I would get there, and those kind of things. So here's just some fun examples and cases, little tiny cancers that we get to go after. And because it's always fun, right? You know, I always tell patients, I was like, it's a really good thing that we get to go after and do this with a fancy piece of equipment, because if I needed to use a regular standard bronchoscope, that means you've got an advanced stage lung cancer, right? All right, if I can go after this with just a regular standard scope, that's an advanced stage malignancy, and the outcome is usually not as good, right? And so I want to be able to go after things as small as possible and be able to find them, right? Same thing here, little tiny lung nodules, to be able to go after those. I'll move over this, but this is a great opportunity to kind of see what the catheter can do. Being able to go out and biopsy something like this. This is a space that is normally only accessible with cardiothoracic surgery, which is in the anterior, or in part of the mediastinum, anterior to the aorta, station 6 lymph nodes. To be able to bend these things the way that we do now is pretty phenomenal. And the same thing here, a little video clip, seeing that needle there going after a biopsy of this little tiny nodule here that is in the medial portion of the upper lobe of the lung. You see it's right here adjacent to the windpipe. But the way that we get there is we start at somebody's mouth, right, and go down through the mouth, drive down through the airway of the lung, right, driving down through the airway and turn left, go way up in here, keep driving until we almost run out of space, and then we go out there towards the medial side. So it's pretty cool what we're able to do nowadays. This is another example here. There's really relatively no lung there in the left side with significant bullous disease. You can see there's a big hot pet avid mass right here. And then being able to go driving that catheter up and kind of poke up through the bullous disease, kind of like a periscope from a submarine. And then you can see that there is an image of what I get to see when I'm doing the procedure, is you can see that mass there inside the chest wall that we were able to biopsy. And this, as you would traditionally, if I would see something like this clinically for a patient, I definitely would believe that this would be a non-small cell malignancy. They normally occur in the periphery, not very common within the chest wall for small cell. But when I saw this clinically, I thought it would probably be something like an adenocarcinoma. Believe it or not, this was a limited stage small cell, and so that's why it's important to go after this stuff, biopsy it, and do it safely without complications. So if you guys see us around, we have a new mobile screening system. You can see a little picture of it there, sponsored by our foundation, that we're going out into the community in the Sand Hills and the surrounding counties. Reach out anytime. This is my email address. Find me on LinkedIn. But thank you guys. We'll entertain any questions for sure.
Wonderful. Thank you so much, Dr. Icard. Thank you. Hey, before we go into the questions here in the audience, I'm going to go ahead and we do actually have a question from our live stream. In fact, I know the person who asked the question. Hey, Rosemary. Is SS RAB, is it SS?
Yes.
Yeah, RAB, the same as EBUS branch, the EBUS branch?
Okay, yeah, that's great. So SSRAB is just an acronym for Shape Sensing Robotic Assisted Bronchoscopy. So that is the kind of the white towered ion system that you saw earlier, the robot that I drive. A EBUS bronchoscopy, or endobronchial ultrasound. That is a scope that has a little tiny ultrasound on it, smaller than the pad of my finger, that we go down into the main airways and are able to look through the wall of the airway under ultrasound to then be able to pass a needle to it. So just like a lady would get an ultrasound of a baby at the time of pregnancy, it's the same exact concept. We use ultrasound waves to generate an image that would find something on the other side of the wall and then biopsy it. The robot is used for peripheral biopsies, so things out in the periphery of the lung. The EBUS bronchoscopy is used for something to biopsy in the center of the chest, where all of the other vital structures and things like that we wouldn't want to stick would be. Okay?
Great, thank you so much. We have a question here from Larry. Oh, you have a mic.
How far away are we from using that for surgery, actually removing the tumor?
They already do that, right? So if you have a procedure today for a lobectomy, the majority of lobectomies in the country are completed right now robotically. That actually just changed as of kind of last year. They crested the more than 50% mark, but most of them are done robotically with a system called the Da Vinci. You may have heard of that or seen it, and it's got little arms and it hangs out over the patient, and it usually is done with three ports. You're talking about through the mouth. No, not going through the mouth. Exterior to the chest. Correct. So we are, I don't know how far we are away from stage 1 treatments here. Believe it or not, the very first transbronchial ablation that was done in the United States was done by my partner, Michael Pritchett at FirstHealth. And so the very first one in the United States was done there. And so I'm privileged to have an opportunity to work with him. Additionally, the very first robotic bronchoscopy that was done in the United States was also done at FirstHealth by Michael Pritchett. So, having a chance to work with the Chest Center of the Carolinas and pushing the envelope is a great opportunity for me. So that's one of the reasons why I'm down there.
Real quick, your bronchoscopy, the robotic, is that done under full anesthesia or?
Yes,
Okay, thank you.
Yeah, under general anesthesia, patients would go off to sleep with general anesthesia, have a endotracheal tube or a ventilator connected to them while they breathe, and then we drive the scope at that point. Patients wake up afterwards and go home the same day.
I have a question about the screening rate, and you mentioned adherence being so low, and from what I understand from other people who are in screening programs, there's a lot of confusion about billing, and the patient gets billed incorrectly. It should be covered 100% by insurance, if they have insurance, and unless it's diagnostic, and then there might be copays. Now, my question is, and I suspect your adherence rate is much higher than that, but during the National Lung Screening Trial, they remarked in the New England Journal of Medicine how incredibly driven these patients were to adhere to that. How can you explain the difference now that there's low adherence? Because initially it was very high.
Yeah, well, when you think about a clinical trial, patients are usually assigned coordinators that are part of that, right? And so these coordinators reach out to patients and call them, and people also, human beings, myself included, or whoever that's ever participated in a clinical trial. My wife, for example, has participated in a clinical trial. She was actively engaged in that process, right? And sometimes when we have conversations with patients about getting a screening exam done, they may not be as engaged, right? And you say, and maybe like I'm just trying to pull them along a little bit, thinking, okay, I really think you should get this done. I think you should get this done. And then I might see them the following year and ask them again, and they're like, okay, finally, I'll do it just for you. And they'll do it one time, and it's negative, and they're like, all right, I'm good. And they'll go on about their life, right? And they don't necessarily understand the complexities of what screening actually means. And screening means that we follow you over time so that when we do find something that's small, I have a reference to be able to decide. And I hope I explained a little bit why it's important to know what that baseline is, because I really care about the history and the morphology and what it looks like and how it behaves and all of those things, because 9 times out of 10, nodules are benign, and I am trying to sift through who's got a cancer and who doesn't. And you've got to do that when they're really tiny and small.
I have a question.
Yeah.
With the robotic, if you were to take a biopsy,
Yep.
like when I had mine done, it was so hard to find it. Like he couldn't really, because it was too close to the heart and too close to everything.
Okay.
So he couldn't really get a good biopsy.
Okay.
So if you use the robotic, can you get a better, like can you get in there
Oh,
better?
yeah.
Like can you really get a better takeout of?
Yeah, absolutely. Do you mind me asking how long ago? August of this?
23.
August 23, okay. Yes, I mean, that would be the ideal situation, yeah, because we do robotic bronchoscopy. We also have CT scan imaging in the room. So when I am biopsying somebody and I need to make sure that I know exactly where I'm at, I can spin you in the room, right? So I don't have any question as to whether or not we're accessing the space. Okay.
It's probably much smaller too, because I really had a problem afterwards.
Correct. It's very small. The catheter is only 3.5 millimeters.
Oh, wow.
Okay, 3.5 millimeters.
Is this something that patients should ask for when they are, when they're told that they need this procedure?
Gosh, that's a biased question for me. It's what I do for a living, right?
We're all about empowerment here. So.
Right. So, I mean, from my standpoint, if something could be done that is least risk, right? So I have to think about it. I always tell patients, it's like, would I do it if my mama needed it, right? Well, if my mama needed it, that's probably what I would do, right? Because it's the least chance of having some kind of complication related to it. Because no matter what we do, right, it comes with a risk-benefit discussion of, hey, I've got to put you to sleep. Hey, I'm going to have to biopsy something. If, last time I checked, everybody bleeds red. So anytime you cut something that's going to bleed, there's always a chance of a complication related to doing a procedure on a patient. And so what is the least risk something that I can do that is going to give us an answer? And the nice part is the way that ours is set up and the way that I operate is that we have a pathologist in the room. So I'm biopsying and I'm trying to get as much information as I can to get an answer right then, right? So everybody operates a little bit differently, but fortunate to have the system that we have at FirstHealth. Yep. Oh yeah, go ahead. Whoever.
I didn't receive a biopsy in my lung because I've had, from smoking for years and years, had other problems.
Yep.
When they operated on me to see what was going on in there, they cut me in about 5 different places and sent in robots. Mm-hmm. Is that what you guys do?
Yes. So it sounded more like you had a thoracic surgery, right? So they've used like a Da Vinci system or something that would have put that in the side of the chest. So it is similar. We just do not we don't have any. So the procedure that I would do has no cuts, no stitches, no pain. Okay.
Oh, I should have seen you.
Goes no stitches, no pain. Goes through the mouth.
Oh, a couple.
Yeah, go ahead.
In the beginning, you talked about like risk factors with smokers and non-smokers.
Yes.
What wasn't mentioned was that if you had radiation for breast cancer years ago when they first started and they used
mantle
way
cell
too
radiation.
much,
Yeah.
and yet insurance won't cover that. That's not fair. I mean, I wasn't a smoker, got breast cancer, followed the advice, and so he guaranteed me I would never have breast cancer again, which was right. He didn't tell me I'd get small cell lung cancer.
Yeah.
So, but that should be added. So do what you can to get that added.
Absolutely,
So that,
absolutely. You know, Dusty and I, we had the privilege of being up with the Go-To Foundation group up on Capitol Hill a couple of, it was just a couple of weeks ago, wasn't it? And, you know, one of the things that we were up there talking about was the importance of even biomarker testing. And that is something that is not mandated for coverage in North Carolina. And so these are all things that we have to be mindful of and we have to know exists because of patients like yourself, right? You know, and you also, you know, encourage people to understand that this is one of the reasons why we have to follow up on those things when patients get treatments long term. Because you're right, when they were doing mantle cell or your radiation for the chest, at the time they may have not known, right? We don't know the long term effects.
The other thing was about bronchoscopies. Sometimes they can't get at it. Like I had 3 nodules. They did the bronchoscopy. This was February of 2024, and they couldn't do anything because the nodules were on too big of blood vessels. Are you familiar with that? That was their reason that they couldn't get.
Gosh, what's the right way to say this? It depends on who's doing it, right? Right? Depends on who's doing it, okay? And I'm happy to chat with you afterwards too, but you know, there is plenty of ways to access the chest and feeling comfortable in being able to do so depending upon what equipment you have available, right? And it is not the same in every system.
Okay, and I got an infection from that bronchoscopy.
Yeah, it's not the same in every system. Every system's different.
I think we need to move on. Dr.
Yep.
Icard, thank you so much
You're
for
welcome.
all the wonderful work you do. Thank you. Yeah.